Okay, moving on now to the head. We'll start with face and scalp. Looking here at the major bones of the skull, and there'll be more, these aren't all of them, but we can see here from anterior to posterior, this is the facial skeleton here. The mandible we know about, that's the lower jawbone. The upper jawbone is the maxilla here in green. And then the upper hard part of the cheek, underlying that is something called the zygomatic bone. The forehead here is composed mostly of frontal bone. And then the side of the cranial cavity here, we have parietal bone, which literally means the wall. And then this is the temporal bone in pink, which is a complex bone with lots and lots of features. We've already talked about the mastoid process and the styloid process of the temporal bone. This is the sphenoid bone right here, which we'll talk quite a bit about. This has a lot of features. It's a very, very complex bone. It's an unpaired bone. There's only one of them, but it has a lot of features. And then back here, the back of the skull is going to be the occipital bone in purple. Now, I want to direct your attention to these holes right here. This is the orbit right here, commonly called the eye socket, but the proper term now is orbit, and that's where the eyeball hangs out. And this is the external auditory or external acoustic meatus, which is the bony ear hole right here, so the ear would be right here. Now, the anatomical position of the skull is related to these two openings right here, the orbit and the external acoustic meatus. And basically, there's a plane right here that we define anatomically that's going to run along the inferior margin of the orbit and the superior margin of the external auditory meatus. And that plane right there is referred to as the orbital meatal plane for the orbit and the meatus, or the Frankfurt plane. Now, in the anatomical position, normally when we're standing at rest looking forward, this orbital meatal plane lies exactly in the horizontal. So that's normally how we hold our head in position here. That plane, that's going to pass through the inferior margin of the orbit, right underneath the eye, and the superior margin, the external auditory meatus, this thing will be horizontal. Now, looking at this in the coronal plane, this is pretty straightforward. This is referred to as interpupillary line right there, a line that passes through both pupils of the eyes, and that line also should be horizontal as well. That's more straightforward and obvious. And so this is the anatomical position of the head. Both of these planes should be horizontal. Now, looking at the face, looking at the skull from the anterior side, again in blue here, this is the frontal bone, the bone underlying the forehead. We've already mentioned the zygomatic bone is the bony upper part of the cheek, and here's the maxilla and mandible. These are the jaw bones. A couple new bones right here. These are nasal bones. This is a paired bone. There's a right one and a left one. That's all, you're seeing all of it right there. There's not much of the nasal bones right there. Now, correlating this with surface anatomy, we can see right here the frontal bone, again, is the forehead. Nasal bone is sort of the upper part of the nose. You can see the nose here. Most of the nose, at least the lower half of the nose, consists of skin and cartilage. The upper part of the nose actually has a bony skeleton underlying it. And like I said, the zygomatic bone is sort of that upper part of the cheek right there, the hard part of the cheek. The softer part of the cheek is composed mostly of muscle down here overlying a portion of the mandible right here known as the ramus. From the side, again, get a better view of the skeleton of the nose, or the composition of the nose, and it's the upper part of the nose right here that's an underlying nasal bone, as well as a portion of the maxilla is making a contribution as well. But most of the nose here, the lower part of the nose, is mostly just skin and cartilage. That's why when you look at a skull, there's this gaping hole right there where basically the skin and cartilage are decomposed. Most of our skulls in laboratory are fake, so it basically simulates decomposition of those soft tissues. Again, there's the frontal bone right there. Maxilla would correlate again with the upper jaw underlying the upper lip. And then there's the hard part of the cheek, upper part of the cheek, the zygomatic bone. Then the mandible is the lower jaw and chin. Sphenoid bone would be located roughly right about here. Filling in this whole space right here is mostly a giant thick muscle called the temporalis muscle, which we'll talk about when we talk about the infratemporal fossa and the TMJ. Underlying that are a series of bones we'll talk about in more detail when we do the cranial fossa. This portion right here, and you can actually feel this right here. This is actually the frontal process of the zygomatic bone. That portion of the zygomatic bone is articulating with the frontal bone, so we call it the frontal process of the zygomatic bone, and that's actually a palpable bone, sort of just lateral and behind the eye, and you can feel that posterior margin of that frontal process right there, and then directly behind that you feel mostly muscle, temporalis muscle. Deep to that would be a portion of the sphenoid bone right here known as the greater wing. Again, we'll add more and more details about the sphenoid bone as we continue. Then there's the temporal bone right there, which is again a complex bone composing this thing right here, most of the zygomatic arch, which is a horizontal ridge of bone that's extremely easily palpable. And over here is the external auditory meatus, the external ear hole, and then you have here the mastoid process. This is parietal bone and occipital bone. Now, what we're going to do is, for descriptive purposes, we're going to divide the face into different regions, and I do want you to know these regions. And they have, this is showing the regions here, and we're going to correlate those with the underlying osteology right here. So just looking at these one by one, this is the frontal region of the face right there, which is pretty much the forehead. Underlying that is the frontal bone right there. This is referred to as the nasal region, basically everything in and around the nose, correlating with this region right there. Those are nasal bones. That's the left nasal bone right there, and a little bit of the maxilla. Okay, the orbital region of the face is the area in and around the orbit here, basically around the orbit and the orbit itself, where the eye hangs out. Directly below the orbital region is something called the infraorbital region right there. Infra meaning inferior to, so the region directly inferior to the eye right there. That correlates with this part of the skull right here. Pretty much all maxilla underlying that. And then over here, this is the oral region, area around the mouth right there is oral region. That correlates with this right here. And I had told you once before, mentum means chin, and so this is the mental region here, which correlates with this portion of the mandible. And then we go back to the cheek, and the cheek really is divided into three regions right here. First, there's that upper hard part of the cheek with underlying zygomatic bone. That's referred to as the zygomatic region of the face. And then the softer part of the cheek, inferiorly, is divided into two regions. Anteriorly, we have something called a buccal or buccal region, which correlates to this part of the skull right here. And then back here, we have something called, just right in front of the ear, around the ear, that's the auricular region. The auricle is that cartilaginous part of the ear. Directly anterior to that, this portion of the cheek, again, I think of this as the back half of that soft part of the cheek. This is referred to as the parotid masseteric region of the face. It's named for the two main constituents that we find there. We have a parotid gland, which is a saliva gland, which lives right here. Now, parotid just means next to the ear. It's literally para means near or next to, otis is ear, so parotid just literally means the gland that's next to the ear. It lives right about here. And then underlying that, deep to that, is a big muscle of mastication, a big chewing muscle called the masseter muscle. And so this region of the face is referred to, is basically named after those two structures, the parotid gland and the masseter muscle, and that would be this region of the skull right here. And then finally, this is the temporal region up here, what we normally call the temple, sort of that side of the head right there. So again, I want you to know the regions of the face. We make reference to regions of the face when there's skin on the face, and this is the underlying bony anatomy corresponding to each region. Okay, so now we're going to move into muscles of facial expression, of which we've already talked about one. Of course, when we talked about the neck, we already talked about the platysma muscle right here, which is the only muscle of facial expression that we find in the neck, and it basically does this. Kind of makes the anterior neck skin kind of taut. And so this is a review. We've already seen the platysma muscle, but now we're going to talk about all the other, well, not all of the other, but many of the other muscles of facial expression. I'm not going to cover all the muscles of facial expression. There are something like 24. I'm just going to cover the big players and skip some of the smaller ones. Okay, so here's one right here. So basically what we have when we look at muscles of facial expression, they're basically three big sphincter muscles. One for the mouth, and then one each for the eyes. The right eye, and there's a left eye over here as well. So they're big sphincter muscles, and when you look at them, you can actually see them going all the way around. They're muscles that basically go all the way around that opening, whatever opening happens to be. Just like here we see a muscle going all the way around. Those sphincter muscles are called orbicularis muscles. This one in particular is called the orbicularis oris muscle, oris for mouth. Okay, so that's the big sphincter muscle of the mouth. When it contracts, so you can see it here, and when it contracts, this is basically what it does. So this is the muscle that's going to close the mouth tightly. So os is mouth, oris means of the mouth. So orbicularis oris, oris means of the mouth. Okay, and then we have sphincter muscles for the eyes, and these muscles right here, all of this right here is referred to as the orbicularis oculi muscle. Oculus is eye, oculi means of the eye. So that's orbicularis oculi right there, and that's basically the sphincter that closes the eye tightly. Now it actually has three parts. I only want you to know two of the three parts, and the parts are these. First, there's an orbital part that goes around the outside right here. Okay, this is basically lining the bone around the orbit, the orbital margin right here. This is not on the eyelid. This is referred to as the orbital part of the orbicularis oculi muscle. And again, that's really the muscle that does this. When you squeeze your eye closed tightly, okay, so tightly close your eye, that's the orbital part of your orbicularis oculi that's doing that. But there's also this thin little palpebral part right here. Palpebra means eyelid. Okay, so the palpebral part is a part that we actually find deep to the skin of the upper eyelid. Okay, so the skin here is very, very thin, and right underneath that we have muscle. That's the palpebral part of the orbicularis oculi, and that's very much involved in blinking. So that muscle will essentially twitch from time to time, forming a blink, and that's important for redistributing lacrimal fluid from time to time. Okay, so this is a key function of the orbicularis oculi muscle. There's a little gland up here that we'll talk about when we talk about the orbit up here called the lacrimal gland. It's sort of high and lateral within the orbit, and it's constantly secreting lacrimal fluid, tear fluid, that's going to circulate across the surface of the eyeball and basically be taken up by some ducts over here on the medial side. But that fluid has to be redistributed as a nice monolayer across the entire anterior surface of the eye on a regular basis. Otherwise, the cornea could dry out and ulcerate. Okay, and we'll talk about Bell's palsy in a second, where this is an important consideration clinically. And so that's why we blink, to basically redistribute that fluid on a regular basis, prevent our cornea from drying out. All right, now the rest of the muscles of facial expression are largely strap muscles, meaning they're muscles where we have these three sphincters here, here, and the other one would be over here. The rest of the muscles are more linear muscles, kind of strap-like muscles whose job it is to pull and tug and pull on different parts of the facial skin, creating different kinds of expressions. And so we'll start with this guy. This is a muscle that we find deep to the skin of the forehead called the frontalis muscle, or sometimes it's referred to as the frontal belly of the occipital frontalis muscle. I don't really care which one you call it. There's a greater muscle. There's another muscle in back called the occipitalis, and we're going to see it's continuous with the frontalis. So let's call this the frontalis muscle, and this is what it does. It basically raises the eyebrows. You can see the forehead is wrinkly here, so that look of surprise, or whatever you would describe that expression, that's being mediated by the frontalis muscle basically pulling up on the eyebrow skin. That's frontalis. There's another muscle right here. We have a muscle that's taking its origin more or less off the zygomatic bone, which would be right about here, and that's going to head down this way and insert here on the angle of the mouth, what we commonly refer to as the what we commonly refer to as the corner of the mouth is more properly referred to as the angle of the mouth, or angulus oris. Okay, and this muscle right here, taking its origin here and inserting here, is capable of raising, pulling in this direction, the angle of the mouth to create this kind of look right here. Now you do it on both sides and you get a smile. This looks more like a sneer, but if you do it bilaterally, Yeah, it's going to look more like a smile. This is the zygomaticus major muscle. Its job is to pull up on the angle of the mouth. There's also a zygomaticus minor muscle right here, but I don't care about it. I just want you to know zygomaticus major, but because there's a minor, you got to remember to put this major in here. Okay, so that's zygomaticus major. And then here also inserting into the angle of the mouth, but this time pulling down on the angle, is this guy right here. And this guy is called the depressor anguli oris, literally the depressor of the angle of the mouth. And it creates that look. So this would be maybe a frowny face right there. You pull down on the corners of the mouth bilaterally and you get a frown. So depressor anguli oris right there. That's this muscle here. You notice it again, orientation is sort of superolateral a little bit, or straight up, and it inserts right here in the angle. You want to distinguish it from this muscle right here, which is something else. Okay, and then right here we have this muscle coming straight down this way, and it's relatively deep, but you see it over here coming straight down, and it's going to kind of insert more into the upper lip, closer to the midline than the zygomaticus major did. So this muscle right here is going to lift up on the upper lip, and so its name is basically named exactly for that. Labium is lip, labii means of the lip. And so what we have here is the levator labii superioris, okay, because we have two lips. There's an upper lip and there's a lower lip. And so labium is lip, labium superioris is the upper lip, levator labii superioris is the elevator of the upper lip. And so there it is. That's that muscle right there. And it's going to pull up on the upper lip. So he's using his both the right and the left levator labii superioris muscles to raise his upper lip to create that kind of look. Okay. And then we have a muscle down here that's going to pull down on the lower lip. And aptly, it's called the depressor labii inferioris. It's going to pull down on the lower lip, and that's this muscle right here. Notice the fiber orientation is more superomedial. Okay, it's going to insert more along here, closer to the midline, and so that creates this kind of look right here. All right. And then there's one more muscle facial expression that's actually pretty important when we talk about mastication in a little bit. Not today, but in the next lecture, we'll talk about this muscle again and its important role in mastication. And this guy is called the buccinator muscle, or some people probably say buccinator muscle. So that's, I say buccinator, but that's it right there. And this muscle is actually pretty deep. Unlike all these other muscles, which are right underneath the skin because they're inserting into the skin and their job is to move skin around, this muscle actually is pretty deep. What you don't see, what's been removed here, is something called the buccal fat pad or buccal fat pad. There's a big chunk of fat right here, and overlying that is skin. And so you dig all that out, and finally you get down to this buccinator. The buccinator muscle, unlike all the other muscles of facial expression, it's actually closer to the inside of the cheek. To get to the buccinator muscle, it's actually faster to go in the mouth and work this way and dig off the mucosa of the cheek, and you're more likely to find the buccinator faster. But basically it does this right here. Basically its job is to put tension on the side of the cheek, like when you're blowing up a balloon or something. Okay, so moving on from muscles of facial expression, let's see what else we find in the face. Now we got a little bit of bony anatomy right here. This is referred to as a zygomatic arch, and this is something you can palpate very easily on the side of your face right here. It's basically a communication between the zygomatic bone, which is right about here, and the temporal bone, which is here. They're going to communicate via this zygomatic arch right here. Each bone makes a little bit of a contribution to it. Now, down here, it's sort of the softer part of the cheek, we find a number of important structures here. This guy right here is called the masseter muscle. This is not a muscle of facial expression. This is a very different kind of muscle. This is a muscle of mastication. It's a chewing muscle, and we'll spend a lot of time on mastication in the next lecture when we talk about the infratemporal fossa and the TMJ. But that's the masseter muscle right there. Okay, and that's a palpable muscle, really, you can find in that softer back part of your cheek. And then right here, this is the parotid gland. I mentioned this before as well. This is a big saliva gland that's sitting directly anterior to the ear. This is right underneath the skin, and a little bit of fascia right here is all it takes to get to this. A little bit of fascia covering it up called the parotid fascia, but this is pretty close to the skin, big gland. And then right here, it has a duct. There's going to be a duct that leaves the parotid gland and goes across the masseter muscle right here to the anterior edge of the muscle right there. And that's the parotid duct, okay? And that's going to carry saliva from the parotid gland to the oral cavity. And we can get a better view of that here. This is a front-on view, an anterior view. There's the parotid gland right there. This is the masseter muscle, and there's the parotid duct passing across the masseter muscle, running from posterior to anterior. You can see when it gets to the anterior edge of the muscle, what it does, the parotid gland, or excuse me, the parotid duct, is going to hook inward and go deep. And what it's going to do is pierce the buccinator muscle. And once it does that, the only thing it has to penetrate then is the mucosa of the cheek, and just like that, the duct is inside the oral cavity where it secretes saliva. Where this duct is secreting saliva is roughly just near the second maxillary molar. You can see this duct working. If you suck on a lemon really, really hard for about a minute, really lower the pH of your oral cavity, and look in a mirror, if you get lucky, you'll see this thing squirting in like a fire hose. I did it once. I'm not going to do it again, but it's kind of cool if you just do it one time, and you can actually see it spraying in. Just look it up in the roof of your mouth, just inside your cheek, actually. Don't look at your hard palate. Look at the inside of your cheek, just opposite, again, your second maxillary molar. If you've had your wisdom teeth out, that would be your last tooth. And you can see this thing spraying in. Okay, moving on. Let's talk a little bit about the innervation of muscles of facial expression. Okay, osteology, again, this is review. This is the mastoid process. We're looking at the inferior aspect of the skull right here. The mandible has been removed. This is the mastoid process of the temporal bone right there, and there's a styloid process of the temporal bone, that little spike right there. Again, we've covered that before, but in between them, you can see a little opening. There's a little hole right here. This is one of many holes, openings that you're going to learn in this skull. This is called the stylomastoid foramen. It's just named for the fact that it's right between the styloid process and the mastoid process. It's directly in between them, and so it's called the stylomastoid foramen. And this is where cranial nerve 7, the facial nerve, is going to exit the skull. Facial nerve is going to come right out of that hole, and on the other side, you can see where it's going. There it goes right there. It comes out of that stylomastoid foramen on this side, and the course of the nerve is going to be out this way. It's going to go out kind of superficially, go anteriorly all the way to the face, where we find muscles of facial expression. And this nerve is going to be motor to those muscles. Okay, so here we see it. Here's all our muscles of facial expression right here. Everybody except this guy. This is the masseter muscle. He's not a muscle of facial expression. He's supplied by a different nerve. But all these guys, even the platysma muscle, all these guys right here are going to be supplied by this nerve. There's the mastoid process. Sternocleidomastoid's right there. There's the external jugular vein. And we can see the facial nerve coming out of the stylomastoid foramen right about there. The styloid process is over here somewhere. We can't see it. It's deep to the parotid gland and the masseter muscle and a lot of other things. And here's the facial nerve coming out of that foramen. And you can see it's going to go anteriorly and then bust up in a whole bunch of branches. They're going to go to different muscles of facial expression. Okay. Now, when it does that, what it's going to do, it actually passes through the parotid gland in the process. Actually, it doesn't go deep to the parotid gland. It doesn't go superficial to it. The thing just goes right through it. It doesn't do anything to the parotid gland as far as I'm aware. It has no action. It doesn't innervate the parotid gland in any way that I'm aware of, but it nevertheless goes through it before it breaks up into branches within the parotid gland, and those branches go in different directions. So I do want you to know the main branches of the facial nerve. And so here, looking at this view, we can see it passing through the parotid gland before it finds all those branches, forms all those branches. Okay. Now, altogether, there are 6 branches, but we generally only care about 5 of them. Veterinarians or vet students do care about this branch right here. This branch is called the posterior auricular branch of cranial nerve 7, or the posterior auricular branch of the facial nerve. And this is going to go up and supply muscles that insert into the ear. These are muscles of facial expression. We do have them, but they don't do a whole lot in people. These are called auricularis muscles. There's an anterior and a middle and a posterior one. Those insert into the ears and move the ear around. And so if you can wiggle your ears, that means you can really utilize these muscles well. Most people can't. Now, these are the muscles, when we talk about moving the ear around, so these are the muscles that a cat would use to move its ears around. Cats can move their ears. Other animals can move their ears as well. And so this branch is very, very important to those animals, as are these muscles. But we don't care about other animals. We only care about people in this school. Okay. Now, you become a physical therapist for dogs and cats is a different story. I don't know if such a thing exists. Okay, but we don't care about this posterior auricular branch. What we care about are these 5 branches here that go anteriorly to the muscles of facial expression on the front of the face. Okay, these are the muscles of facial expression that are important to people. And basically, they're named for where they go. This branch right here that crosses the zygomatic arch, which is from here to here, is called the temporal branch. Okay, ultimately it's going to pass the zygomatic arch, over the zygomatic arch towards the temporal region of the face. This guy right here is going to cross over the zygomatic bone right here. There's a zygomaticus major muscle. Sorry, right there's a zygomaticus major right there. This guy crosses over the zygomatic bone, heading towards the eye. This is referred to as the zygomatic branch. This guy going directly anterior, okay, this guy probably and this guy as well. These are all referred to as buccal or buccal branches, and they tend to go parallel, run in parallel with the parotid duct right there. Okay, those are the buccal or buccal branches. I don't care how you pronounce it. Okay, this one probably as well, to be honest. Okay, this guy right here going down under the mouth, okay, heading towards the chin, he's called the mandibular branch of cranial nerve 7. And then finally, there's a cervical branch heading down this way into the neck. And so for all these, we would say temporal branch of cranial nerve 7, or the temporal branch of the facial nerve, zygomatic branch of 7, buccal branch of the facial nerve, and so on and so forth. That's the name of these guys. Okay? And they're just named for where they go. Now, the cervical branch of 7, okay, again, this facial nerve is going to be motor to muscles of facial expression. The cervical branch, as you might imagine, there's one muscle of facial expression in the neck, and so this guy is motor to the platysma muscle right there. For the rest of these, you just sort of guesstimate. I'm not going to ask you very specifically what branch supplies any given muscle of facial expression. I just want you to know the muscles. I want you to know the branches. I probably am not going to ask you a question like which branch of facial nerve supplies zygomaticus major. It's not that critical to know that. Okay? But I do want you to be able to identify the branches and know where they go. Now, to remember the branches, there are some mnemonics. I'm not a big fan of mnemonics, but what the heck? One famous mnemonic is this one: to Zanzibar by motor car. Temporal, zygomatic, buccal, mandibular, cervical. Okay, to Zanzibar by motor car. TZBMC. Okay, again, anatomically it should be pretty obvious what their names are. Okay, and this is a stupid mnemonic because Zanzibar, I believe, is an island. You can't get there by motor car. That's why I don't like mnemonics, because they don't make any sense. Other mnemonics that are famous for remembering the branches of the facial nerve: two zebras bit my cat is another one. And another one is tells Ziggy Bob Marley called. There are also some dirty ones that I'm not going to share with you. You can look them up on your own. Now, important clinical correlation relating to the facial nerve as it supplies the muscles of facial expression is Bell's palsy, which is basically an idiopathic paralysis or weakness of muscles of facial expression secondary to some sort of injury to the facial nerve. And again, for the most part, it's not really clear what happens. Occasionally it is. I mean, the facial nerve can be damaged, for example, during a forceps delivery of a baby. Babies don't have a fully developed mastoid process, which means the facial nerve is less protected as it's coming out of the stylomastoid foramen. So occasionally the facial nerve can get damaged in an infant during delivery. But in most instances, there'll suddenly be a more or less sudden onset dysfunction of the facial nerve. Very often people will wake up with paralysis of muscles of facial expression secondary to some sort of injury to the facial nerve. It's not really clear what happens. And there'll be some eventual recovery. It is, after all, a peripheral nerve. These nerves will regenerate eventually. Okay? But essentially, when we look at Bell's palsy, this is how it presents. So here's a young lady right here who's smiling. We're looking at the left side of her face right here. And you can see right here a number of things that are important. The left angle of her mouth is being raised, presumably by her zygomaticus major. And you see a nice nasolabial fold, this little crease right here in your face between the nose and the angle of the mouth is called the nasolabial fold, and usually that'll be nice and pronounced during a smile. And the other thing she's doing is squinting. When we smile naturally, and you may or may not learn in neuroscience the difference between something called a Duchenne smile and a pyramidal smile. A Duchenne smile is a genuine smile that we smile produced by genuine emotion. It's done by a different part of the brain than the other type of smile, but I'm not going to get into that because this is not a neuroscience course. But generally, during a genuine smile, we usually will squint a little bit. Okay? Now, so this part of her face, the left side of her face, looks fine. Now, contrast that with the right side of her face, and you can see the difference. For one thing, we can see the right angle of her mouth is drooping. Okay, there's problems with the muscles that are attempting to raise the right angle of her mouth. The zygomaticus major appears to be weakened or paralyzed. We don't see a pronounced nasolabial fold on the right side, and notice her right eye is wide open. It's not squinting. And so this is a total Bell's palsy on the right side. Now note, it could be just one branch of the facial nerve that's affected, and so you might have weakness or paralysis of just one or two muscles of facial expression, or if the nerve is damaged further back, more proximally, you might have loss of all the branches, creating this type of appearance here, a total devastating loss of function, all the muscles of facial expression, pretty much. Now, the biggest concern here, other than the problems that she can't produce facial expression, that's going to be a problem in and of itself. But the other thing is that she can't close her eye. The orbicularis oculi muscle also is paralyzed. And this is a concern because we need that muscle to redistribute lacrimal fluid across her cornea going this way. Again, the gland is about here. The fluid is taken up by ducts on this side, and it can't be redistributed because she can't close her eye. And this is a concern because this can lead to her eye drying out, corneal ulceration, and she could lose this eye basically. And so care has to be taken to make sure that this eye is lubricated until function is recovered. Okay, and yeah, I already pointed that out. Nasolabial fold on the other side is absent. Okay, so that's the facial nerve, which is motor of the muscles of facial expression. Now let's talk about sensory innervation of the face. Okay, and that's going to be cranial nerve 5, or the trigeminal nerve. Okay, again, we always use Roman numerals with cranial nerves. So what we're looking at here, just to get oriented, this is if we remove the skull cap, called the calva, pop that off, and then remove the brain, and now we're looking at the inside of the skull base right here. These are called the cranial fossae. This is called the anterior cranial fossa, middle cranial fossa, posterior cranial fossa, and we'll deal with this later. We'll have a lecture on the cranial fossae later, but I just want to point out a few things right away. This is the trigeminal nerve right here that's coming out of the pons. Okay, the pons is part of the brainstem that's been removed right here, and there's the cut end of the nerve. That's the trigeminal nerve there. And here we can see sort of a large structure right here called the trigeminal ganglion. And this is analogous to the spinal ganglia or dorsal root ganglia that we talked about when we talked about the back. So remember, the spinal ganglia contained cell bodies of neurons that were sensory to dermatomes, sensory to skin. We had those all up and down the spinal cord. Well, you kind of think of this as one more spinal ganglion or dorsal root ganglion, but for the face. We don't call it spinal ganglion. His name is the trigeminal ganglion, but it's the same concept. This little bulge-like structure here is full of the cell bodies of sensory neurons innervating the skin of the face, okay, providing sensory innervation to the face. Now we work this way anteriorly. What we see next is that the trigeminal nerve, just beyond the trigeminal ganglion, is going to split up into 3 divisions. Okay, so going from superior to inferior, they're all going through different openings in the skull. We'll talk about those in a different lecture. Okay, but from superior to inferior, the 3 divisions are the ophthalmic division of the trigeminal nerve. So we abbreviate that cranial nerve V1. V is Roman numeral 5, subscript 1 for the first division. There's a maxillary division of the trigeminal nerve, abbreviated cranial nerve V2. And going this way, downward, is the mandibular division of the trigeminal nerve, or cranial nerve V3. Okay, and so these guys are going to be sensory to different parts of the face. And so these are the trigeminal dermatomes. And again, all of this, these are all spinal dermatomes here. This is C2 dermatome here. Remember, there is no C1 dermatome. C2 dermatome is also this and this as well. C3 would be more here, and so on and so forth. But the face right here, you might think of this as the anterior half of the head. All of this skin is not supplied by spinal nerves. It's all supplied by the trigeminal nerve, cranial nerve 5. Okay, and so these are the 3 trigeminal dermatomes, one for each of those 3 divisions. So V1, or the ophthalmic division, is going to be everything here in green. And the key landmarks here are the forehead, upper eyelid, and the cornea, the actual anterior surface of the eye, and sort of the bridge of the nose and the tip of the nose. Okay, upper eyelid, forehead, the tip of the nose here, and the bridge of the nose, and the cornea, that's all V1. The V2, or maxillary division of the trigeminal nerve, that dermatome consists of the lower eyelid and the upper lip. And then the mandibular division, cranial nerve V3, is going to be chin and lower lip, and all of this, and then this weird vertical strip that goes straight up this way, right in front of the, just anterior to the ear as well. All of this is the V3 dermatome. So you should be able to tell me for any part of the face which division of the trigeminal nerve is sensory to it. Okay, now the other thing to point out here, just in terms of the anatomy, is that remember I told you the facial nerve likes to come out the stylomastoid foramen and go around the outside to get to muscles of facial expression. Trigeminal nerve, on the other hand, takes a different course. It likes to go right through the head. I drew this yellow line here just to show this is the midline right here, the head right here. And we're much closer to the midline. The facial nerve wants to be out here. Trigeminal nerve doesn't like to go around the outside of the head to get to the face. It pretty much goes right through the head to get to the face. And we're going to see branches basically popping out of holes right about here in this parasagittal plane right here, this far from the midline. Okay, and that's what we see here. So we have a series of big openings here, and there are also some little openings, like this guy right here is also an opening for a branch of the trigeminal nerve. I'm not going to ask you to know this one or this one. I just want you to know these 3 big ones right here. This guy right here, remember this is the orbit right here. This guy above the orbit is called the supraorbital foramen. Technically, this guy right here, because it's incomplete, is called the supraorbital notch, but that's a kind of a pedantic point that I don't care about. This would be a supraorbital foramen. This is a supraorbital notch. I don't really care. You can have 2 notches or 2 foramina, or a notch on this side and a foramen on this side, or vice versa. It just doesn't matter. Who cares? We're going to call them all supraorbital foramina. Okay, and then below the orbit we have an infraorbital foramen in the maxilla. Note the supraorbital foramen is in the frontal bone. Infraorbital foramen is in the maxilla. And then down here, just lateral and posterior to the chin, we have the mental foramen, or mental foramina if you count both of them. Okay, and that's in the mandible. Okay, so these 3 big openings all transmit a major branch of each respective division of the trigeminal nerve. And so coming out through the supraorbital foramen and basically going up onto the forehead, supplying this skin right here, is something called the supraorbital nerve, which is passing through the supraorbital foramen. And this is a branch ultimately of the ophthalmic division of the trigeminal nerve. There are some intermediate nerves in between. It's not a direct branch of it. We'll talk about that more when we talk about the orbit. But this guy is ultimately coming from V1, Infraorbital nerve is popping out of the infraorbital foramen. That's a branch of V2, the maxillary division of cranial nerve 5. And then the mental nerve is passing out of the mental foramen, and that's ultimately a branch of V3. And again, he2 is actually an intermediate nerve in between that I'll talk about when I talk about the infratemporal fossa. Okay, something called the inferior alveolar nerve. He doesn't come directly off V3, but ultimately it's coming from V3. So this is V3 dermatome here. And this is right here. All this would be V2 dermatome. This is V1 dermatome. So it makes sense when you look at where these nerves are coming from. So now, just as the facial nerve had a clinical correlate in Bell's palsy, so too does the trigeminal nerve in its sensory innervation of the face. And the clinical correlate here is trigeminal neuralgia, or tic douloureux. This is an idiopathic pain syndrome relating to the face. We don't know what causes it. It says here maybe due to compression of cranial nerve 5 at the brainstem origin. Maybe. It could be something else. But for some reason, the nerve gets irritated and starts transmitting pain. The pain is very intense. It's a lancinating or cutting pain in the face, and it's been reported that patients suffer so much that they actually contemplate suicide. And so this is trigeminal neuralgia. Basically, it's a facial pain syndrome relating to dysfunctional trigeminal nerve. Okay, looking at arteries, blood supply to the face. I already mentioned coming off the external carotid artery, passing this way into the submandibular triangle, deep usually to the submandibular gland, which is right about here, and then it climbs onto the face. That's the facial artery. And you can see it's kind of wiggly, kind of passes along the cheek right there, ultimately heading alongside the nose, ultimately towards the medial aspect of the orbit. Facial artery, as it's climbing the face, gives rise to branches. One that goes into the lower lip, the other one that goes in the upper lip, and these are the inferior and superior labial arteries respectively. So that's the facial artery right there. And again, it's always kind of wiggly right here. That's a key landmark there you're going to look for to identify it. Okay. And then looking at other branches, we follow the external carotid up here. We want to terminate. There's the occipital artery there. That was the last branch I asked you to know back in the anterior triangle of the neck. We're going to follow the external carotid up, and right here is where it ends, right here, by forming two terminal branches. One is called the maxillary artery, which is an artery that actually passes into a space back here called the infratemporal fossa, which will be the subject of our next lecture. The infratemporal fossa is right there. Ultimately, it's going to give rise to a branch that's going to pass out through the infraorbital foramen. You can see right here, that would be the infraorbital artery right there. Okay. Also, it's going to give rise to a branch that goes in here. We'll talk about this when we do the infratemporal fossa. Okay. I'll tell you right now, that's the inferior alveolar artery, but don't worry about it right now. And it's ultimately going to send off a branch that pops through the mental foramen called the mental artery. So there are arteries, the moral of the story, that pop out that with names corresponding the same name as the nerves that pop out of those holes. Going back to our external carotid artery, again, it's going to terminate right here by forming the maxillary artery. The other branch that continues to ascend, starting right here, heading up into the scalp, okay, all of this, that's the superficial temporal artery. Okay, that's this guy right here. And note, here's the external auditory meatus right here. Okay, so the ear would be right there, and this guy is running directly anterior to the ear. That's a superficial temporal artery. Okay, and so these are our pulse points of the face. Again, facial artery is passing this way onto the face right about here. Right about here is where it crosses the inferior border of the mandible and into the face. Okay, that's the pulse point for the facial artery. And then right here, directly anterior to the ear, is the pulse point for the superficial temporal artery. And what you want to find is your zygomatic arch, that bony strut, horizontal strut right there. Find your tragus, which is this part of your ear right there, and palpate directly anterior to that, right on that zygomatic arch, right there on the bone. That's your best bet for finding your superficial temporal artery pulse. Okay, it's usually pretty easy to find. I've not had much luck finding my facial artery pulse. Be quite honest, you might have better luck. But these are the two major pulse points of the face I want you to know. Okay, veins. Okay, I don't want you to know all these veins. I just want you to know this guy. That somehow, some way, it varies depending on the individual, it's going to find its way either into the external or internal jugular vein. Don't worry about it. I just want you to be able to identify it in the face. Okay, and this is the facial vein right there. It runs parallel to the facial artery, but there's usually a good inch between them, quite honestly. They don't run side by side ever. Whereas the facial artery is wiggly, okay, and closer and more anterior. The facial vein is more posteriorly set and perfectly straight, more or less. The reason the facial artery has to be wiggly, right, is because we have to open our mouth and we can't bust the artery as we stretch it. There's got to be some slack in here. It's got to be like a little spring. So when we open our mouth, the facial artery doesn't get ruptured. Okay, that's why it's curly. Whereas the facial vein is set far enough back that it's really not much of a problem. Okay, let's move on to the scalp real quick. Scalp has 5 layers, okay? And we have this little famous mnemonic we use to remember the layers. I don't know how effective it is, but I'm going to give it to you anyway. The mnemonic's going to spell the word scalp, we'll see. But basically the 5 layers are these. The most superficial layer, the one with the hair coming out of it, maybe, is skin. Okay, that's not too surprising. Directly deep to that is the second layer, known as the dense connective tissue layer. So the C in connective is the C in the mnemonic. This is the dense connective tissue layer, and this is where we find most of the vasculature, the scalp, in here. These arteries and veins tend to hang out in this layer right here. And there's a lot of connective tissue in here that puts a lot of traction on those blood vessels. We'll see why that's relevant in a moment. Okay, so here they are right here. Okay, so the skin has been removed from this side, and directly deep to that, we're looking at that dense connective tissue layer there. Directly deep to that, we're going to see there's some muscle. Okay, and here's where we see all the arteries and veins of the scalp right here. And like I said, there's a lot of dense connective tissue in here that tends to put traction on these blood vessels. Which leads us to this clinical correlation right here, and that is simply that scalp wounds tend to bleed far more profusely than you might expect given the size of the wound. And the reason for this is all about the anatomy. The skin of the scalp is pulled tightly over the skull, and that puts a lot of traction on the skin. You can see here's a laceration in the scalp right there, and you can see what's happened here. Each edge of the laceration, the skin on this side and the skin on this side, are being pulled away from each other, creating this gaping wound here. And we can actually see the skull underneath there. Okay, and the reason for that, again, is that the skin is being wrapped over the skull, and there's dense connective tissue here as well. And basically, these wounds in the scalp don't close up very easily by themselves. This has to be sutured shut. And the end result also is that because this wound is pulling, the two edges are pulling away from each other, any blood vessels in there that happen to be ruptured are going to be basically splayed open and kept open, and they're going to continue to bleed profusely. They don't really clot up very well. And so the end point being that inch for inch for any kind of cut that you see in the scalp is going to bleed more profusely than a similar sized cut elsewhere in the body. This is why scalp wounds, again, are famous for bleeding like mad. I actually got slashed by a hockey stick when I was a kid, and it was ended up being 7 stitches to close it. It was in my forehead, which is technically part of the scalp technically. And same principles apply there. But I put my hands on my face, pulled them away. For all intents and purposes, I might as well have put my hands in a can of red paint. They were so just saturated with blood. It took 7 sutures to close it. It was nothing. It just bled like mad. And that's typical of these types of wounds in the scalp. Moving on to the next layer. Third layer. Okay, A in scalp is for aponeurosis. Okay, what we find, this is really the muscular layer right there, and that's where we find muscles of facial expression. I already talked about the frontalis muscle. There's also a muscle in back called the occipitalis. Quite honestly, I don't really know what it does or why it's important. I wouldn't worry about it. And then there's an intervening aponeurosis that connects those two muscles together, called the Galea aponeurotica, or the epicranial aponeurosis. Galea is a helmet. So Galea aponeurotica means a helmet of aponeurosis, basically, or you can call it epicranial aponeurosis, which literally means aponeurosis on top of the head. But the whole idea is that you have two muscles here that are connected together by an intervening aponeurosis. So sometimes we call these the occipital frontalis muscles, which have a frontal belly and an occipital belly. That's the alternative nomenclature it's used to refer to this muscle. I don't really care which one you use, but this is the third layer right here. Okay, and there it is right there. We already saw this image before. There's our frontalis muscle right there. There's the occipitalis muscle in back, and there's the intervening aponeurosis right there. That's the galea aponeurotica right there in between. Okay, next layer, this fourth layer right here is the loose connective tissue layer. That's the L in scalp. There's our mnemonic. Okay, loose connective tissue layer. And when we dissect in the laboratory and we turn down the scalp to get to the skull, ultimately to remove the brain, this is the layer right here that basically the scalp is removed. This loose connective tissue is a natural potential space here that can be opened up very easily by a little bit of pressure. What I'm trying to say is you can basically just peel the scalp right off the bone, and that plane that opens up is this loose connective tissue layer here. And then deep to that, what's considered technically to be the fifth layer of the scalp is actually the periosteum that's sitting right on the cranial bone. The periosteum of skull bone is referred to as pericranium. That's the P in our mnemonic right there. So it's just the outer periosteum of this bone. It's technically considered to be part of the scalp. Periosteum is basically soft tissue that's on the bone, contains a little bit of blood supply, some nerves, and some other things. Okay? Okay, that leads us to our last clinical correlation right here. Now, just get oriented here. This is a T2 weighted MRI. T2 weighted MRI lights up fluid, especially water or aqueous solutions, bright white. This is cerebral spinal fluid here within the brain. The brain itself is lighting up because it's mostly basically a gelatin. It contains a lot of water. The black layer here is cranial bone. The cranial bone, especially the compact portion of the bone, doesn't contain much water, and so it shows up as black. And what we see right here, this is the scalp, and that's showing up bright because it's wet. Scalp is wet. And right here we can see this white structure right here forming superficial to the cranial bone and deep to most of the scalp. And what we have here is basically a hematoma forming in that fourth layer, that loose connective tissue layer, deep to the galea aponeurotica. And so we refer to this as a subgaleal hematoma. It's basically a hematoma that's basically forming in the scalp. And basically it's forming that fourth layer, that loose connective tissue layer, where the scalp can be detached from the cranial bone very, very easily. Okay, we see here this is a CT, and I know this is CT because in this case the bone is lit up white. CT is X-ray, and X-rays are stopped by bone, and so bone ends up being white in a CT. Okay, so that's cranial bone going all the way around, and you can see this is a hematoma right here forming outside that perimeter of that cranial bone, and that's another subgaleal hematoma right there. And so this is one of several different types of hematomas we're going to cover. We'll talk about epidurals and subdurals and subarachnoids later. This is the first of four that I'll talk about, subgaleal hematoma. And again, this is outside the skull within the scalp. All right, so that's it for the face and scalp. If you have any questions, let me know.